Professor Daiana Stolz from Basel. She's the head of the research group of the pulmonary division. She has done a lot of studies in her group with biomarkers, especially for procalcitonin in COPD exacerbation and pneumonia, and for the use of guiding antibiotic therapy. Please, Daiana.
Thank you, dear Chairman, dear colleagues. Thank you very much for the invitation to be here today. I have been asked to talk about biomarkers in the differentiation of acute dyspnea, and those are my conflicts. And I would like to start as well by showing you a case of a 70-year-old obese male that presented with acute dyspnea. He was a patient that was known to us. He suffers from severe COPD. You have an FEV1 of 40%, post-bronchodilator 44%, no hyperinflation, some air trapping, and you see no response to bronchodilator. The patient reported that he had, since 3 days, increased breathlessness with some kind of pressure, oppression, or pain in the left thorax. He had swollen legs, and he had unchanged productive cough with yellow-white sputum. He had a history of smoking, 100 pack years, very frequent exacerbations, 5 to 6 times a year. He did not tolerate a phosphodiesterase 4 inhibitor, and he had a lot of symptoms. He was out of breath by walking on the floor, and a lot of sputum and other symptoms as assessed by the CAT. Because he is a professional patient, he had at home already antibiotics and steroids, and he took them when these symptoms started, but did not improve, so he called us because he wanted to have a bronchoscopy to get rid of the sputum he could not cough up. At examination, he didn't have any change in his auscultation. He had a breath frequency of 18 per minute, prolonged expiration, no new cardiac murmurs, leg edema, and he was on a very broad COPD therapy, including bronchodilators, inhaled steroids, theophylline, azithromycin, and he also had a diabetes. He did not have any known cardiac disease. So we did an evaluation when he came, and as you see here, start by looking at our first biomarkers. The dimers were just on the borderline to normal, 0.5. He had been in the northern eye in the north of Germany, so he was on the train for some hours. He had no increase in the C-reactive protein, a normal procalcitonin, but he had a pathologic cardiac evaluation with an increase in troponin. So the question is, how do you manage this patient? Which examinations do you have to do? And we excluded pulmonary embolism. We did an ECG, and in my pulmonary eyes, I didn't see any major changes here suggestive of acute cardiac ischemia. So I was not really sure what to do, and I think this is a situation that we encounter very frequently. How do we decide how to go on? What is the diagnosis of this patient? Patients have different presentations, and so does acute dyspnea. It has different phases. And if you see here, as suggested, you have, besides the more uncommon causes, we have a lot of diseases that happen very commonly, and sometimes they come at the same time. They can happen in the same patient. So we have pulmonary embolism, we have exacerbation of COPD, by itself or together with pneumonia, but we also have patients with cardiac disease, with acute coronary syndrome and congestive heart failure. And in my eyes, without any biomarkers, we are in a bad situation. We have not enough weapons to try to find out what is going on, so we do have some problems. And there is a lot of literature looking at biomarkers for dyspnea, and they are usually separated in COPD, infection, and cardiac disease. And by the size of these figures, I try to represent how much literature there is. We have a lot of literature on prohormones, including procalcitonin, but also C-reactive protein, troponin, the dimers, and other markers. What do we expect from a biomarker? Ideally, we would measure something somewhere, preferentially in the blood, and this measure would tell us what is the diagnosis of the patient. Even better if we wouldn't have to see the patient, no anamnesis, no examination, we have a diagnosis. This is unfortunately not possible. We would also like to know, if we don't know exactly what this patient has, how do I have to treat this patient? So do I have to give antibiotics? Do I have to give steroids, diuretics? Do I have to treat an acute coronary syndrome? This would be a good thing to have as an answer from a biomarker. We also would like to know where to treat this patient. What is the prognosis? Should I keep this patient at the emergency room, put him or her on the ward, send to the intensive care, send home? That would be very nice to know. And ideally, we could save money by assessing the situation by using a cheap biomarker. So biomarkers could have diagnostic value, but also prognostic value in the situation. And unfortunately, there is no established diagnostic biomarker that can really safely differentiate the etiology of acute dyspnea. So the idea of measuring something in blood that will tell us what this patient has is not realistic. And with the example of troponin, if we go back in the literature and look at the possible causes of troponin elevation, we see different ones. I was a bit surprised not to find a relative cardiac ischemia in patients with COPD in this list. And I think there is a lot of literature suggesting that troponin is indeed increased in patients with acute exacerbations of COPD. 20 to 80% of these patients do have an increase in troponin, and this is strongly associated with prognosis. So patients with troponin increase have an increased risk of dying by 70%, and troponin T seems to be more predictive than troponin I. But it's important to recognize that most of these biomarkers are non-specific. So they are increased in several diseases. And this is represented here by a recently published study that looked at pro-ANP. And as you see, it's not only increased in cardiac conditions, but also in pulmonary embolism, in neoplasia, in pneumonia, and several other conditions. So we do need a diagnostic algorithm for patients with presenting with dyspnea, and for sure we need to take into account not only cardiac disease but also pulmonary disease in this algorithm. There is a very strong link between COPD and cardiovascular disease. In fact, most patients with COPD die with COPD due to cardiovascular disease. They do not die because of COPD. The cardiovascular diseases are the most common cause of death in these patients, followed by neoplasia, and just at a third position, the COPD itself cause mortality. And as you see, there is a whole pathophysiologic association between these two diseases, with the idea that lung inflammation and oxidative stress can lead to endothelial lesion and could cause an acute ischemic disease. So there is a clear increased risk of myocardial infarction associated with COPD as a chronic disease, even adjusted for the smoking. So it's not only that patients with COPD and cardiovascular disease have a shared risk factor because they smoked, but even if you correct for the smoking history, still there is an increased risk of myocardial infarction in the population with COPD. And there is also increasing data suggesting that there is an increased risk of myocardial infarction in patients presenting with acute exacerbation of COPD. If we talk about COPD, it's important to recognize that COPD is not really one disease. It's a condition that has different presentations. So this patient population is very heterogeneous. It's very difficult to say by looking at the patient which kind of disease he has, but this COPD has very different presentations. And unfortunately, we do not have any biomarker currently that enable us to diagnose the disease, or to diagnose an exacerbation of COPD, or to predict disease progression. But in my view, there is enough evidence supporting the use of biomarkers to predict therapy response at stable state, to restrict useless therapy at exacerbation, and to predict survival. And in my view, the most promising biomarker that we have now to diagnose an acute exacerbation would be an experimental one called vasoactive intestinal peptide. It has a very gastroenterological name, but it's actually the most abundant peptide in the lung, so it's actually a lung peptide, and there is a very high area under the curve suggesting that this peptide might be associated sensitively with an exacerbation of COPD, but we do need more data on that. In any case, the biomarkers cannot substitute the clinical judgment. They can be used to support a clinical decision, but they do not provide us a definitive diagnosis. And I give you an example. If we talk about patients with COPD and cardiovascular disease, they have always, or they have very commonly, a combination of diseases when they present to the emergency room, and you can have two conditions. So you can have a patient with COPD with an acute exacerbation of the disease and potentially with pneumonia. So maybe we have to start talking about a condition called pneumonic exacerbation, because there is indeed a difference about a patient with a COPD as a comorbidity presenting with an acute pneumonia, parenchymal infection, or an exacerbation of the COPD symptoms being caused by parenchymal infiltrate. The prognosis of these patients is different, and maybe this is a condition that has to be described separately. And you might think it's very easy to make the diagnosis of pneumonia. You might use a chest X-ray or ultrasound, as we just heard from Roland, but actually this is a very difficult thing to do. And there is new data suggesting that depending on which kind of imaging you use, you might get different responses. So we assume that a chest X-ray would be more sensitive than will be less sensitive than the CT scan. And this study performed in France has compared the performance here of the chest X-ray and the CT scan. And they found out that in 1/3 of the cases in which the patients had no infiltrate in the chest X-ray, they did have an infiltrate in the CT scan. But the other way around, it was also true. 1/3 of the patients with an infiltrate in the CT scan did not have or did have a CT and an infiltrate in the X-ray. So if you perform the CT, you change the classification of the disease in 60% of the cases. So in 2/3 of these patients, you change the diagnosis and treatment because you performed a CT scan. You initiated antibiotics in 16% of the cases based on the CT findings and discontinued in 10% of the cases based on CT findings. So if we talk about pneumonia, it depends, has it been diagnosed by CT scan or by chest X-ray? The influence of that in the prognosis and diagnosis must be or might be different. And in these cases, I think biomarkers could help. If we look at the performance of procalcitonin and CRP, for example, they are both increased in patients with both exacerbations and pneumonia, they can be increased, but they tend to be higher in patients with parenchymal infection, with pneumonia in different studies, and the suggested cutoff for CRP in a study was 50 milligrams per liter to differentiate between exacerbation and pneumonia. I also told you that biomarkers can be used to restrict useless therapy in some patients, and I might remind you that antibiotics, they are always recommended in patients with pneumonia, but they do not really provide an improvement in most patients with a COPD exacerbation, except for those in the ventilator. They need to receive antibiotics. For all others, there is a mild improvement associated with this therapy. This is the last placebo-controlled trial performed evaluating the efficacy of this therapy in acute exacerbation. There was no difference for the primary endpoint. Procalcitonin can decrease the antibiotic use at exacerbation by 50%, and there is no detrimental effect of withholding antibiotics in this population, even if we look at what happened to these patients for the next 6 months. And there is nowadays more than 4,000 patients randomized to be treated according to procalcitonin levels at different settings, from intensive care to the emergency room, GP praxis, and for all studies there is the same reduction in antibiotic use without any adverse event at the end. Can we also use C-reactive protein to decide on the therapy? There is a post-hoc analysis of the Daniel study, of this study on a placebo-controlled use of antibiotics at the exacerbation, suggesting that patients with increased CRP over 50 might benefit from antibiotics. And there is also a study that used CRP to guide antibiotic therapy in COPD. The therapy was withheld in patients with very low levels, less than 20 milligrams per liter, and it was always prescribed in patients with very high levels, over 100 milligrams per liter. And you see that there was a significant decrease in the use of antibiotics in this population only in patients with Antonison 3 exacerbations, so with mild exacerbations, and those are exacerbations that shouldn't be treated with antibiotics at the first place. So it doesn't seem to work as well as it does if you use procalcitonin to decide which patients should not be treated. Another therapy that you might withhold based on biomarkers is the use of oral steroids. There is one nice study performed in England suggesting that in patients with low eosinophils at exacerbation, there is no advantage of giving oral steroids. As a matter of fact, patients treated with steroids with low eosinophils had a detrimental effect of oral steroids at exacerbation and had more deterioration and treatment failure as compared to those that received placebo. For the last part, I would like to discuss with you the use of biomarkers to predict survival in patients with dyspnea. And I want to remind you that the prognosis of COPD exacerbation is actually worse than patients with myocardial infarction. That's a very dangerous disease as well, and we do not seem to do as well as the cardiologists do in treating these patients. Procalcitonin is associated with adverse events and mortality at exacerbation of COPD, but also at other diseases at the emergency department, such as respiratory tract infections and chronic bronchitis, as well as pneumonia. Also, copeptin, a prohormone, increased in exacerbations of COPD and in cardiac conditions, seems to be associated with the prognosis. So patients with a high level and a history of previous exacerbations of COPD have a much poorer prognosis as compared to those with low level and no history of previous exacerbation. And the same is true for patients with increased pro-ANP. They have a decreased survival. Here it seems that there is a difference between the cardiac peptides. We couldn't see any association between BNP and the mortality rate at 6 months and 2 years, but we did see that patients with an increased BNP had to be more often treated at the intensive care unit. Fibrinogen is the new kid on the block in the COPD literature. It seems to be associated with a poor prognosis, but here we have the problem that the studies evaluating this in COPD excluded patients with cardiovascular conditions, and this is the population that we usually see, a combination of congestive heart failure or ischemic heart disease and COPD. And lastly, the proadrenomedulin is also associated with survival in exacerbations of COPD, but as it is also associated with survival in patients with other conditions causing breathlessness, such as heart failure, neoplasia, and pneumonia, so it's very unspecific, and it seems to be related, the prognostic value of this marker seems to be related to its cardiovascular information, but also to the association of this biomarker with an anti-inflammatory effect on the bronchial epithelial cells and smooth muscle cells in humans. We could show that if you treat human cells of patients with COPD and asthma with adrenomedulin, and if we stimulate those cells with an inflammatory stimulus, you can decrease the inflammation with this treatment of adrenomedulin. So it seems to be also a factor decreasing inflammation in this patient population. We could also show that if you combine the best predictive score for mortality in COPD with the adrenomedulin biomarker, you can increase the prediction of this score, so you can more easily differentiate between survivors and non-survivors in patients with COPD. And it seems that this improvement is around 27%, meaning a significant improvement in the ability of the score to predict which patients will pass away and which ones will survive. And lastly, we thought about having a combination of these cardiac markers and inflammatory markers to predict prognosis. And this came out with a nice editorial suggesting that a combination of biomarkers may be more than just a sum that is greater than its parts. It reminds us that COPD is a heterogeneous disease, and maybe we need different biomarkers to assess this heterogeneity, and that cardiovascular compromise is really strongly linked to mortality. And this this panel has been suggested, and you see that there is a linear increase of mortality risk for patients with increase in known 1, 2, and 3 biomarkers, and this association with mortality remains significant even if you adjust for smoking, for all comorbidities, and for the lung function. So back to our patient, the 7-year-old male with acute dyspnea. We decided to talk to the cardiologist. We repeated blood sampling after 3 hours, and we didn't see any dynamic in troponin. There was no increase in this marker. We performed a bronchoscopy, which depicted neutrophilia, but no bacterial infection. He was on antibiotics already, no viral infection. And we performed an echocardiography, which suggested a normal left ventricular ejection fraction with some indirect evidence of increased pulmonary arterial pressure, no tricuspidal insufficiency. And we sent him home with aspirin and took him back to get a myocardial perfusion scintigraphy that did not evidence any signs of ischemia, any scar, and no regional motility disturbance. So we do think that the problem was an acute exacerbation of COPD with some kind of relative myocardial ischemia and no really vascular disease. So if I put this all together, I think biomarkers can be helpful to evaluate dyspnea. They are not disease-specific, so they do not substitute the clinical judgment. Probably we would need different biomarkers to answer different questions. I do think that we have enough evidence to say that procalcitonin can identify exacerbations of COPD which do not require antibiotics, and probably low blood eosinophils indicate a detrimental effect of oral steroid in this population. And for all prohormones, there is an association with survival prediction, both in COPD and cardiovascular disease. Thank you very much for your attention.
Thank you very much, Daiana.